So it's a great honor to start the session with a talk on CRRT, and I was asked to address the question, who is suitable for CRRT, what type of CRRT, and how? These are my disclosures. They have not affected what I'm going to say in the next 15 minutes. Undoubtedly, CRRT is an essential component of modern critical care. I would put it to you, it's the ideal method of achieving ideal fluid management because it allows us to manage fluid continuously in an individualized manner to respond to the dynamic needs of the patient. It's also a method to minimize any fluctuations in fluid shifts and fluid status. And in fact, the importance of fluid management, of personalized, individualized fluid management was evaluated and explored in an ACCI meeting last year organized by Professor Ronco. And it was very clear that fluid management is important, but is not well done in modern critical care. And again, CRRT is one of the ways to do this, to make it possible. Because during CRRT, clearly, we can remove fluid, and this is why we initiate it very oftenly, but we also can add fluid, we can increase fluid status, we can correct hypovolemia if necessary, and we can keep the patient even at an even level if required. In addition, it allows and provides continuous solute removal, similar to our native kidneys, and it avoids metabolic fluctuations, in contrast to intermittent renal replacement therapy. And again, in contrast to intermittent renal replacement therapy, it makes drug dosing much easier because we have reliable clearance and can therefore adjust our drugs accordingly. And I put it to you, it's like most other continuous therapies, like ventilation, inotropes, drugs, it is much easier to be integrated compared to intermittent renal replacement therapy. In fact, it's often considered to be an important component of the whole multi-organ support package. So numerous reasons why CRRT is one of our integral components. Now the question was, who is suitable for CRRT? And this was one of the questions explored in the ACCI meeting last year. A group looked at the reasons why patients may need renal replacement therapy, and again combined this with timing. So who are the patients who need it, and at what point do we consider renal replacement therapy? And the ACCI group developed a new concept which moved a little bit away from a baseline, from a creatinine cutoff or a fluid balance cutoff. And essentially, they acknowledged that the kidneys have a finite capacity. Even if you've got normal kidney function, your kidneys can only do so much. Clearly, if you've got impaired kidney function, then your renal reserve is limited. And at the same time, during critical illness, each patient, to different degrees, is faced with a metabolic load and a fluid load. And as long as these two are in balance, it's okay because the kidneys are coping with the fluid and metabolic demand placed on them. But as soon as there is an imbalance, as soon as capacity is inadequate, either because there's not enough renal reserve or because the metabolic or fluid load are so high that even the best kidney can't cope, that's the time where there's clearly inequality and imbalance, and that's the time where renal support may help, would be indicated to support the kidneys which are no longer coping with the demand. And therefore, the person who should be considered for CRRT is the person who, at that point in time, does not have adequate kidney function to cope with the demands placed on the body. At the same time, it needs to be kept in mind that this may be a person with all other additional acute medical and chronic comorbidities. And it needs to be kept in mind that CRRT, as I've already said, is a therapy which provides a bit of stability and avoids fluctuations in fluid status and metabolic fluctuations, especially shifts in osmotically active substances like urea and ammonia. And again, in comparison to intermittent renal replacement therapy, as demonstrated here in red, or SLED here in green, with continuous renal replacement therapy, you have much more controlled and stable removal of metabolic waste products, in this case urea, BUN. So the first part of the question was, who should be considered for CRRT? And I put it to you, the person or the patient who needs continuous fluid management and metabolic clearance and cannot tolerate any metabolic fluctuations or swings in fluid status, and does not have adequate native kidney function to cope with the demand, should be considered. And this in particularly applies to those who are on other forms of organ support, including extracorporeal respiratory support or significant hemodynamic support. It also includes patients with significant brain injury of any form, including encephalopathy and edema. The second part of the title was what? Well, there are 3 types of CRRT. I leave PED out at this point. And essentially, we may be able to choose between convective or diffusive therapies. Zach Ricky from Rome looked at the question whether either modality, whether convective versus diffusive methods, were advantageous. And he looked at solute removal in 15 sessions of continuous hemodialysis compared to 15 sessions of hemofiltration. The dose of renal replacement therapy was kept static and was the same in both arms. And as you can see here, when you look at beta-2 microglobulin, or look at creatinine or urea, solute removal was very similar with both modalities when provided continuously. So they concluded that convective hemodialysis and convective hemofiltration at 35 mL per kilo per hour, as it was kept constant here, offered comparable removal of small and middle molecular weight solutes. And the removal was predictable and persisted up to 48 hours. So with regards to the type of CRRT, either modality, convective or diffusive, appears to be adequate and acceptable. The next question is how? How should we provide CRRT? Now, clearly, we should provide it in the best optimal manner by a team experienced and trained in this technique. And we would like to do it according to the patient's needs, which clearly means the patient needs an individualized prescription. And I would put it to you that most of us think that's what we do. But actually, in real life, it's very clear that my practice is very different from the practice of my colleagues, and my targets may be different. And in fact, when we audit our own practice, large variation and variability is obvious. And it turns out there's actually no quality standard in CRRT. And this is an area which has bothered and concerned some people for quite a while, including Sean Backshaw from Canada. And he, to this effect, conducted a systematic review to look at the literature to explore what the current quality indicators and quality standards for CRRT should be. And not surprisingly, he found there was a large heterogeneous collection of different definitions used to describe quality and safety of CRRT. It's just an example. Most CRRT studies comment in one way or another on filter life. But really, when you look at these studies, it's clear that they all describe use different criteria to describe premature filter clotting. from just filter clotting within 24 hours to a raised TMP. The same applies to solute clearance. How do we know whether the solute clearance we're achieving is adequate and safe and is the target to be used across the unit? Different units, again, different departments, different investigators have used various different parameters and cutoffs to describe their quality and to describe their efficacy of treatment. And the same can be said for bleeding. So if you look at studies where they compare different anticoagulation methods, the way bleeding is reported is very variable, from just any event of bleeding to major bleeding, studies where they only counted major bleeding leading to 2 units of blood transfusion and hemodynamic instability. Professor Ronco felt this was a key element of CRRT and again dedicated a whole working group to address this issue in the ADCI meeting last year. And again, the group essentially concluded what I've already said. When reviewing the literature, there was wide practice variation in the delivery of CRRT, and quality of care of CRRT is very difficult to describe. Although we all think we probably do the best, it's impossible at the moment to compare different units and different practices because there are no quality indicators and there are no benchmarks. And as a consensus, the group felt that there was an urgent need to address this problem, to identify quality indicators and to make it possible to benchmark different practices and different hospitals. So I'm afraid the question how to do it, I can't quite address. But I'd like to conclude that with regards to who should be considered for CRRT, it's the person with an inadequate renal capacity at the particular time where the capacity is insufficient to deal with the metabolic and fluid demands placed on the body, who at the time cannot tolerate any fluid or metabolic fluctuations. With regards to the type of CRRT, it appears that convective and diffusive modalities are effective at removing small and metal molecules. And with regards to how, it's clear that we want to do it in a safe manner, according to the patient's needs, using an individualized prescription. But with regards to high-quality CRRT, I'm afraid at this point we don't have any indicators and we don't have any form to benchmark. Thank you very much.
Thank you very much for this very interesting talk. We have a few minutes for a question. Do you have any question in the audience? Continue. Maybe.
Thank you for the concise, elegant summary. You mentioned advantages of CRT. Shouldn't we also stress anticoagulation? Citrate anticoagulation is not available very broadly during intermittent therapy, but has become a standard in continuous therapy, and probably this offers some more advantages also for the patient, or don't you think so?
I mean, you could say CRRT has a disadvantage that it needs anticoagulation, and at least we've solved it with citrate. So the proponents of intermittent say one advantage of intermittent is you could do it without anticoagulation and the blood is exposed to plastic for a shorter time, and you needing something, an additional medication, either citrate or heparin, is a disadvantage of CRRT. But you're right, at least we've addressed it by discovering a method of doing it without systemic anticoagulation, and by finding adequate ways for all of us to be taught in this technique.
Thank you. Any question? Okay, I have a question for your medical team and paramedics. How do you implement educational course to improve the quality in continuous renal replacement therapy?
Well, that's very difficult. For a start, in several countries, so including the UK, RIT is a nurse-led therapy. So it's provided by the nurses. And in fairness, they often know more about the practicalities of RIT than the doctors. And there is a very strong, in most units, a very strong educational program, much better than on the medical side. But how do you provide good quality? I think you have to start by doing audits and looking at your own practice and see where you are. How long are your filters actually lasting? How often do they clot off prematurely? How much blood do you lose every time the filter clots? What is your delivered dose? You know what your prescribed dose is. What actually do you deliver? How often do you have interruptions? And only then can you start and improve things. But what is good quality? That's exactly the problem. How long should a filter last? We don't know.
Thank you very much. Any other question? Okay. Thank you very much.